So I was talking about the global burden. So we have around, 1.4 to 1.6 per thousand live births and nearing 3 to 6% of the stillbirths. However, if you look at the Indian data, I was just talking that it's very diverse based on the recent two studies in 2014 and 2018. One thing is very important when we are looking at the prevalence of these disorders which are diagnosed antenatally or soon after birth. So if you look at the prevalence is defined below and is used judiciously, and in fact, it can be used as a proxy for incidence of new cases in a target population, especially when we are dealing with these rare diseases. In this context, if you look what is prevalence, it is the observed number of cases in the live births along with the stillbirths. And the third category is now added, that is elective termination of pregnancy for fetal anomalies, that is ETO-PFA. In countries where this is permitted, and now, as you know, according to the new MTP Act, we have a lot of cases even in India. And that's divided by the number of total births along with the stillbirths. Now you can see that the denominator doesn't have the ETO-PFA. The ETO-PFA is not there in the denominator because that proportion is very minuscule and may not actually change the prevalence. So this is something very important one should know when we are looking at the prevalence of these disorders. If you look at the common things what we see during our day-to-day antenatal counseling, we see disorders of ventricular system, disorders of neural tube defects, midline abnormalities, posterior fossa abnormalities, vascular abnormalities. Rarely the destructive lesions, which are very small, and the cortical formation abnormalities are detected antenatally. So we will be leaving these lesions. So we'll concentrate ourselves on these more commoner ones, what we look in day-to-day practice. So those who are doing the fetal medicine, they would be knowing that there are three important planes in the fetus when we are looking at these CNS disorders. The first one is the transventricular, which passes through the ventricum, and this passes through the ventricle along with one cut at the atrium where the measurement of the ventricle is taken, the occipital horn. The second cut is a transthalamic, so that gives you an idea about the thalamus. It cuts across the thalamus back to the occipital horn. And the third cut is the transcerebellar, where mostly the posterior fossa tumors, the cerebellum, and the associated anomalies are detected. Is my cursor visible, Dr. Akash? Okay. Am I still audible? I just want to confirm. Am I still audible?
Audible,
Yes,
sir. Audible.
Okay. Sorry. Okay. So these are the three planes which are very important. So if you look at the transventricular plane, as I said that this plane cuts to the posterior horn, the choroid plexus, the cavum septum pellucidum. So this is your corpus callosum, cavum septum pellucidum. Is my cursor visible?
yes, sir.
Okay, this is the cavum septum pellucidum, and these are the choroid plexus, and these are the atria. So in this particular view, you can pick up lot number of things. You can find out about the ventriculomegaly, the choroid plexus cyst, the holoporencephaly, skull wall defects, and abnormal skull shapes. So all these are picked up in this particular transventricular plane. Then we have the transthalamic plane. In the transthalamic plane, you have the biparietal diameter that can be taken. Again, there is cavum septum pellucidum, the thalami, third ventricle, choroid plexus, and posterior lateral ventricle. So the abnormalities of the corpus callosum and cavum septum pellucidum are best highlighted in this particular view, and any midline shift is again appreciated in this particular view. So craniosynostosis, we use both the transthalamic as well as the transventricular plane. And the third plane, as I said, is mainly for the posterior fossa abnormalities, and this has the cerebellar lobe, cerebellar vermis, the spina magna, knuckle folds, cerebral peduncles, sparks, and thalami that can be seen. And this is very important to diagnose cerebral hypoplasia, megacisterna magna, Dandy Walker syndrome, and Blacke's pouch. So with that background, let us start with the most common abnormality what we see antenatally, everyone must have faced with these reports coming to you, is the ventricular system abnormalities. In the ventricular system abnormalities, you generally define a ventriculomegaly in this particular plane. When you can see the facts, you can see the cavum septum pellucidum, and you can see the choroid plexus, the atrium, and you measure where there is a parieto-occipital groove. So this is the site where you will measure the ventricular size, and here you can see this ventricle is slightly bigger than the other side, and the difference should be more than 20%. So this is the site generally the radiologist will look at, or the fetal medicine specialist will look at, to diagnose any ventricular abnormalities. Here you can see that this is showing you the choroid plexus cyst. So this is the choroid plexus, and within the choroid plexus you can find a cyst, and again this is a parieto-occipital angle. This is the atrium, and then you have the cavum septum pellucidum and the facts. So the most common abnormality what you see generally is the choroid plexus cyst, and these are 1 to 3% and generally picked up at around 24 to 26 weeks in the fetuses. They're typically found at the level of the atrium or lateral ventricles, and less frequently they may be found in the bodies. They're generally benign, and they are soft markers if they are associated especially with other abnormalities. When structural anomalies present in addition to choroid plexus, the probability of trisomy 18 hikes up to almost 37%. And then you should start searching for features of trisomy 18 in all such cases, like congenital heart diseases. Look at the hands, look at the artery, and look for the growth status and the rocker bottom fluid. So this is one article we published to look at the how to deal with the choroid plexus cyst when it is diagnosed antenatally.
Sorry to interpret again, sir. The voice is breaking. Can you use the laptop microphone itself, sir, rather than the earphone? I think the
I
earphone
think
is causing the problem.
that was creating a problem. Is it okay now?
Yes, sir. But in between it is breaking, sir.
Okay. So I was telling about the how to go about if you detect a choroid plexus cyst. So if you detect a discrete choroid plexus cyst on USG between 16 to 20 weeks, we need to do a dedicated USG and echo to rule out other associated malformations. As I said, that it's an important soft marker, and then we need to rule out other anomalies in that particular baby. So once you do a detailed ultrasound or a TIFA, what you call, then you will have two findings. Either it may be associated with malformation or it may be isolated CPC. The isolated CPC is more common than one which is associated with other malformations. However, if it is associated with malformations, then you should offer karyotype, genetic referral, and a rigorous neurodevelopmental follow-up after birth is indicated. In cases where there is an isolated CPC, then one looks at the maternal age and the serum screen equivalent risk for that particular maternal age. If the risk comes to a risk which is almost more than a risk which is present in a mother who is more than 35-year-old, then you again go for fetal karyotyping, and follow-up antenatal ultrasound is very important. However, if the risk is too low, so much so low that it is almost equal to a risk of a mother who is less than 35 years, then actually this does not require any follow-up USG nor any postnatal USG, and the baby can just be followed up as routine. So that's how you manage the antenatally detected choroid plexus cyst. The second important finding you generally find, and a common one, is the ventriculomegaly. I already told you how to measure for this ventriculomegaly at the level of the atrium at a plane of transventricular section where you will be looking at the cavum septum pellucidum as well as the choroid plexus. So this ventriculomegaly is most frequent CNS abnormality or finding, which is seen in almost 1 in 600 to 700 cases. It is present at the width of the atrium of the lateral ventricle more than 10 mm, regardless of gestation. Now, at that particular level, the size of the ventricle actually does not change from almost 20 weeks to 40 weeks. It is graded as mild when it is 10 to 12 mm, moderate when it is 12.1 to 15 mm, and severe when it is more than 15 mm. Associated abnormalities occur in 7 to 10% of cases. And if it's a large one, that's a severe ventriculomegaly, then obviously the aqueductal stenosis is a common cause and that should be definitely ruled out. What about the outcome of this ventriculomegaly? The ventriculomegaly independently is associated with 10% IUDs, mostly those which are moderate to severe. The chances of normal neurodevelopment in isolated ventriculomegaly is as high as 90 to 95% if it is mild, 80 to 84% if it is moderate. And as soon as the ventriculomegaly gets into the severe category, then the outcome is bleak, wherein the normal developmental outcome is only in 10 to 60% of the cases. So you can see that if you look at the mild and the moderate ventriculomegaly, almost 80 to 85% of the babies would be normally developing. If it's an asymmetrical bilateral dilatation with more than 2 mm difference, prenatal progression should always be looked at. And when the prenatal progression in a week to 2 week basis is more than 3 mm, then again this is associated with white matter abnormalities and the neurodevelopmental outcome is not good. So the prognosis ultimately depends on what is the primary etiology and the presence of associated abnormalities. So to summarize about the ventriculomegaly, if it's an isolated minimal fetal ventriculomegaly, then 80 to 95% will be normal. Comprehensive sonography is still required. Follow up for progression every 2 weeks or 1 week. Toxo and CME should always be ruled out because they are very important causes of this ventriculomegaly. And once the baby is born, you can do an auditory and ophthalmal examination, a repeat cranial ultrasound, and chromosomal studies. And CBC can be done postnatally, again to look at certain infections. However, if this minimal ventriculomegaly is associated with other abnormalities, or there is a severe ventriculomegaly, then up to 60% may be abnormal. You can discuss with the parents, and a termination is also a consideration here if they intend to. One can do a microarray and fetal karyotype. CME toxoplasmosis again is a must. And at times, we have to resort to fetal MRI, especially if the karyotype is normal and one is not able to detect any clear-cut etiology. The next important group of disorders which antenatally get detected are the neural tube defects. The neural tube defects always occur in 1 in 1,000, but they have lot of area variation, so much so that in some areas they may be as frequent as 1 in 500. They are a heterogeneous group of disorders due to failure of closure of neural tube during fetal development. The entities include anencephaly, encephaloceles, cranial meningoceles, and spinal dysgraphism. That includes meningocele, meningomyelocele, and spina bifida occulta. So I would spend some time on this nomenclature because at times it becomes confusing and they are actually not nominated as they should be. So if you have the opening only at the level of the brain, then it is called as anencephaly. If this extends to the spine, then it is called as the craniorachis. So if this extension is not there, then essentially it is anencephaly. If you have a swelling of the brain or meninges in the cranium, then it is called as encephalocele. And then this is a unique abnormality where you will have occipital skull spine defects in the upper part along with severe retroflexion of the head, which is called as anencephaly. Then if you look at the spine, the spina bifida occulta, there is closed asymptomatic entity in which some of the vertebrae are not completely closed. And closed spinal dysgraphism is deficiency of at least 2 vertebrae, and generally this vertebral apartia is covered by a lipid laden cells and the lipid, and hence it is called as the lipomeningocele. A meningocele is protrusion of meninges filled with CSF through the defect of the skull or the spine, and the meningomyelocele is when even the nerve elements are protruding along with the sac. So essentially, if only a vertebra or something is not fused and there are nothing protruding, that is called as spina bifida occulta. If there are two vertebra and it is covered by a fluid sac along with the fat, it is called lipomeningocele. If only the meninges are coming out without the nerve elements in vertebrae more than two which are open, then it is called as the meningocele and then meningomyelocele. So if you look at the prevalence of spina bifida by country and variability in a worldwide systematic review by Zegadjor in 2016, let's focus on to our area, that is Southeast Asia. The India, almost 4 out of 9 available studies had a range of incidence ranging from 16.8 to 31 per 10,000. So you can see that if you take per 1,000, it becomes almost 1.6 to 3.1. And if you take per 100, it is almost 0.3%. So that is how the incidence is there. And as you can see, in some of the countries, it is far less. So there is a lot of variation in reported prevalence of spina bifida. So if you look at the spina bifida, at the first you should be able to classify whether it is an open one or it is a closed one. If it is open, then one should be able to tell whether it is a myelomeningocele or a myelocele, or it may be a myeloschisis. So the difference between myeloschisis and myelocele and myelomeningocele is very important. In myelomeningocele, you will have this swelling, and as you can see here, the neural elements are elevated above the skin. So the neural elements actually are lying above the CSF fluid. So they are at a higher level than the skin level. But if you look at the myelocele, then again these neural elements will be higher, but the CSF would have been ruptured or it will not be present. But the classical thing will be they will be above the skin. But if you look at the rhasischisis, then the neural elements will be at the level or below the skin. So this is very important for the residents to understand that when do you call it as myelomeningocele, a myelocele, or a rhasischisis. If you look at the closed spina bifida, then as we discussed, you only have meningocele or you have lipomeningocele. So this actually describes congenital anomalies due to failure of caudal portion of the neural tube, that is around 28 weeks of conception, with concomitant schisis, that is a fissure on the posterior element of the vertebra. So the open lesions, as I said, the myelomeningocele, which is the most common type of the spina bifida seen in 90% of the cases. And as I said, the elevated above the cutaneous surface is a classical finding in myelomeningocele. And the myelocele or the rhasischisis, it is on the same level of the cutaneous surface. And typically the location is at the lumbosacral region in 80% of the cases. If you look at the closed lesions, they occur in 10% of the cases, and they may be vary having lipomeningocele or lipomyelocele or lipomyelomeningocele, and they are always located in the sacral region. So that is how the characteristics of the closed lesions. So closed lesions are generally more distal, open lesions are generally more proximal, and then the myelomeningocele always has the spinal components which are elevated above the cutaneous surface, unlike that of the rhasischisis or myeloschisis. So let's come to the myelomeningocele, which is the most common variety seen in 90% of the cases. So the myelomeningocele generates a cascade of structural functional changes in the brain. So it's not just enough to look at the spine. Also, there are other abnormalities which occur along with this particular anomaly. The most important is the type 2 Chiari malformation. So this particular swelling compresses on the outlet of the CSF, and this CSF negative pressure drives or herniates a part of the brain into the foramen magnum, and that is called as the cerebellum into the foramen magnum, and that is the type 2 Chiari malformation. So this in turn causes hydrocephalus. So 90% of the lumboraxial lesions, only 10% apparent at birth, and often it can develop later on also. Along with this, they have hip dislocation, hip and knee contractures, varus valgus deformities, bladder dysfunctions, and lower limb hypomotility. These all secondary complications are important because they would decide what would be the outcome of a baby. That's why we should know as to what is the spectrum of the associated anomalies in case of myelomeningocele when it is detected. So the most important thing if you want to prognosticate is first describing the lesion appropriately. So when you get a neural tube defect antenatally, or for that matter, even after birth, it is important to describe this anatomically as well as with associated syndromes. I'll come to that in the next slide. Anatomically, it is described in 4 headings. One, what is the location? So if it is thoracic, thoracolumbar, lumbosacral, or sacral. If you look at the thoracolumbar meningomyelocele or spina bifida, they have poorer prognosis than the lumbar or the lumbosacral. That is why it is important to tell about the location. Second is the covering. Whether it is open, obviously the open have a worse prognosis than the closed. And if it is open, whether it is leaking, because the leaking open meningomyelocele have more chances of early bad outcome because of infection. But one should always tell whether it is associated with hydrocephalus or not, or for that matter, unnatural malformation too. And then finally the size, which tells you that what is the extent of vertebra that are involved. And that also would have a relevance in the prognosis. So if you want to really prognosticate or give an outcome which is very appropriate, then one should know what is the location, what is the covering, whether it is associated with hydrocephalus, and what is the size of the neural tube defect you are dealing with. And once you have done that, then you should also look at the clinical classification, whether this meningomyelocele is associated with multiple other congenital anomalies or it is a part of a syndrome. Either way, the multiple congenital anomaly associated and syndrome associated meningomyelocele have a worse prognosis than isolated meningomyelocele. So once you have all this information, then only one can appropriately prognosticate these babies. So once the myelomeningocele is detected, you have 3 options for the parents. One is a prenatal surgery. I don't think anywhere in India we are doing this prenatal surgery, but there are centers who have recorded appropriate satisfactory results. The second is to continue the pregnancy near term and then do a postnatal repair. And the third is the E2P, elective termination of pregnancy for fetal anomaly. I think the third option is opted by more and more parents in the recent time. And it is by surprise that they identify the neural tube defect in the 3rd trimester near delivery, where the B option is the only option left. So as you can see, as far as the prognosis is concerned, the survival is mainly influenced by the level of the lesion, the openness of the lesion, associated hydrocephalus, and the size of the lesion. And you can see that the developed countries have most of the data where 1-year survival is around 91%, 5-year 89%, and 20 years 85%. So overall, the bottom line is that the survival is not an issue. And whatever deaths they occur in the first week or the first month of life because of infection. The problem is the long-term outcome or the survival intactness. So even though these babies survive, their mobility will be affected such that if the level of the lesion is T12 to L1, they may walk home with braces above hip and they usually prefer wheelchairs. Between L2 and L3, they may walk with braces above knee and hip, usually prefer to use wheelchair for long distance. At L4, they can walk with a assisted foot operated device, braces for short distances, and may prefer to use wheelchair for long distances. L5, S1, they usually walk with short ankle braces. At times, they may use crutches, and S2, S4 may usually walk and they may require some shoe insert. So you can see that as the level goes up, the disability and the mobility limitation goes up. We already discussed the common problems they may face are the neurogenic bladders, bowel incontinence, orthopedic deformities, latex allergies, and tethered cord syndrome. So overall, urinary incontinence is seen in almost more than 50% of these children when they are around 5 years of age, and bowel incontinence is seen in almost three-fourths of these children. So these two disabilities are very important as far as the neural tube defects is concerned. And this was a large registry-based data from US containing almost nearing 5,000 children. This is the inheritance, what you can counsel the parents if they already have a kid with neural tube defect. I think I'll not go into detail. So to summarize, when you look at the spina bifida or the meningomyelocele, the outcome would depend on site size, open or closed, associated hydrocephalus, whether it is associated with multiple congenital anomaly, syndromic, and hence it's very variable. Survival to early childhood in recent time is very good, almost like 90%. Those who are dying in the early time because of infections. Approximately 30% will have some paraplegia and will need some support for the ambulation. Urinary continence and impaired bladder function are seen in almost 60% of the cases, and 70% of the cases would have bowel dysfunction. All above complications are far less. You may reduce to almost half to three-fourths when it is a meningocele compared to meningomyelocele. And there's a huge lot of psychological issues these patients have to face. The next category is the encephalocele. So you can see here that in the occipital region, there is it's the frontal region, the cebocele, and we'll deal with encephalocele. So when you look at the encephalocele, again, there are two subtypes and two types we need to classify. One is based on the location. Based on the location, it may be occipital, which is most common, but unfortunately, this is also having a bad prognosis. Second is the cranial vault, that is a parietal or temporal, and then you have the basal, which is generally not visible. And if you look at the content, depending upon whether the meninges are there, or there is also a brain tissue, it may be a meningocele, which is generally called as a cranial meningocele, or it may be meningoencephalocele. And then again, the meningoencephalocele would have a poorer prognosis compared to cervical meningocele. So prenatally, again, the encephalocele is very easy and generally not missed, diagnosed in 100% of the cases. And it's diagnosed as early as 16 to 20 weeks of gestation. The benefits are you can evaluate the presence of brain tissue in the herniated sac, detect related, unrelated, associated anomalies, and counsel parents about outcomes. Example, risk of neurodevelopmental delay, and address the obstetrical management and postnatal treatment. Most of the affected pregnancies, if they are detected at 16 to 20 weeks, generally are terminated in cases of encephalocele. And hence, if you look at the outcome, just give me 1 minute. So if you look at the outcomes, the isolated small occipital or anterior encephalocele with the average head circumference and normal neurological examination have the best of the outcomes. And the outcomes are less favorable in children with large encephalophiles containing the brain tissue associated with hydrocephalus or other cerebral anomalies. So if you look at the overall survival of these babies, they may survive around 77% at day 1 and also up to 60% in day 20 years. Again, this is the data which is mainly comes from the developed countries, and we don't have a sound data except for some case series in our context. So to summarize, the location, the size, the brain inside the sac, dural sinuses in the sac, hydrocephalus, they are the determinants for the prognosis and outcome. Prognosis is better for frontoethmoidal than for occipital or parietal encephaloceles. 36 to 40% of deaths can occur in the first day of life, and roughly 30 to 60 to 70% survive for 1 year. 48% will have adequate development, 11% will have mild impairment, 16 will have moderate, and 25% will have severe impairment even after the repair of these encephalocele, generally which do not have any. Then you look at the midline abnormalities, the hollow parencephaly, which is seen in 1 in 8,000 live births. This is again most common structural anomaly for the developing forebrain as such. The prognosis is uniformly poorer and consistent with severity of the brain malformation. And again, most of these babies do not make up, or even if they are born, they have a very high mortality, and almost 100% of them have non-intact survival. So they can again be classified into lobar, semi-lobar, lobar, and the microforms. I think those details are not very important. Universally, the prognosis for these holoparencephalies is not that bad, except for that of suboptic dysplasia. If you look at the agenesis of corpus callosum, again it is slightly commoner, seen in 1 in 5,000 live births. Clinical associations with absent or agenesis corpus callosum include other CNS malformations in almost half of the cases, chromosomal abnormalities in 17% of the cases, musculoskeletal defects, and almost 1/4 of them have also the cardiac malformations. The prognosis again depends on extent and severity of the callosal agenesis. Sometimes they are partial, rostral, like that. Here the prognosis may be better, and associated malformations. So the case series which generally is narrated in most of the literature is one of soteriadis. Here we saw that the normal development was seen in 75% of the cases, moderate disability in 14%, and severe disability in 15%. And the similar results were found on long-term outcome. One of the studies by Desporetes also saw that the IQ abilities of a significant proportion of these babies with agenesis of corpus callosum was as near to normal, and that was very assuring among those who do not have any normal neurodevelopmental delay. Then we come to the posterior fossa abnormalities. So before we go to the posterior fossa abnormalities, there's a lot of confusion about the Blake's pouch, the Blake's pouch cyst, and the Dandy-Walker spectrum. So in a Blake's pouch, as you can see that the foramen of Magendie, there is a protrusion of one particular pouch, and this pouch is actually called as a Blake's pouch. But when there is a Blake's pouch, you will see that the fourth ventricle is normal. You can see the cerebellum is normal. The choroid plexus is present at the entry of the foramen of Magendie. Only there is a cyst just in front of foramen of Magendie. So that's the simple Blake's pouch. If you look at a Blake's pouch cyst, this particular swelling or the outpocketing increases so that now there is small shift of the cerebellum, but still the fourth ventricle roof is covered. There is no Vermean hypoplasia. The cerebral lobes are visible, but yes, there is a shift of the choroid plexus from this position to higher up. So that is called as a Blake's pouch cyst. Whereas in a Dandy-Walker syndrome, you can see that this particular part is all absent. So you will find that the roof of the fourth ventricle is all missing. There is a large amount of fluid which is collected. Choroid plexus is almost at the abnormal level, and you will find cerebral and Vermean hypoplasia. So you can see here, this is a normal MRI, and this is one where you can see that this particular fourth ventricle and this cerebellum is completely genetic, and the fourth ventricle roof is opening into a large cyst in the posterior, superior to the tensioria. So that is the classical dandy Walker malformation. In a variant, which at times you maybe see that this in a variant, you'll find that the roof is somehow communicating with this posterior part through a channel. So that is a dandy Walker variant. These are different spectrum of posterior fossa abnormalities, what you can see. And then nonetheless, you can just see that the cisterna magna is large and which communicates with fourth ventricle. Again, that's a dandy Walker variant. And some amount of Vermeer hypoplasia can be seen along with splaying of the cerebellar lobes. So if you look at the posterior fossa and try to classify these cysts into four broad categories, you'll find that either it is a simply cisterna magna, which a length which is more than 10 mm, a dandy Walker malformation or a dandy Walker variant, what we discussed just now, Black's pouch, as I discussed in the first cyst, and it may be an araconite cyst, which is a benign one. So these are the four major posterior fossa cysts which you need to differentiate before prognosticating. So this is another article we published in Perinatology Journal to look at what to do when you detect a posterior fossa cyst. So if you detect a posterior fossa cyst, first try to find out whether it is just an enlarged cisterna magna or it is the cisterna magna is not enlarged. If the cisterna magna is not enlarged to more than 10 mm and it is extrinnsically located cystic lesion which is slightly displaying the cerebellum, then it is probably a araconite cyst which has a good prognosis. If the cerebellum is small, less than 10 percentile for that particular age, meaning that there is cerebellar hypoplasia, then this would have a variable prognosis depending upon what was the etiology for this hypoplastic cerebellum. But however, if there is a fusion of the cerebral hemispheres with the Vermeer agenesis, so here selectively there is Vermeer agenesis with the cisterna magna which is not enlarged, then it is a rhomben kyphoscolin abscesses, and again this has a variable prognosis. So if the cisterna magna is less than 10 mm and you find that there is some abnormality in the cerebellum or the vermis, then the prognosis is variable. But if the cerebellum and vermis are normal and the particular cyst is slightly eccentrically located, then probably it is araconite cyst and it has a good prognosis. So you have to always rule out the araconite cyst when you find a cyst with a normal cisterna magna. Now, if the cisterna magna is enlarged more than 10 mm and it has a communication with ventricle or no communication with fourth ventricle. So if it is communicating with the not communicating with fourth ventricle, then it is simply an enlarged cisterna magna wherein 80 to 90% will have normal neurological development and around 8 to 13% will have some developmental delay which may not be severe. However, if you have a communication with ventricle, then now you have to again determine what are you dealing with. Are you dealing with the black pouch, which has a spontaneous resolution in 50% of the cases and cognitive defects are almost nil? Are you dealing with a vermine hypoplasia, wherein a normal developmental outcome in most of the cases with a recurrence of 1 to 5%? Or we are dealing with dandy Walker malformation, wherein you will find intrauterine death and frequent neurodevelopmental deficits in almost 50% of the cases, or Joubert syndrome, wherein the neurological impairment is almost 100%. So you can see that it all depends whether the cisterna magna is less than 10 mm and associated with cerebellar agenesis or Vermeer agenesis, or it is more than 10 mm with the communication with variable hypoplasia of Mervis and the cerebellum, which decides the outcome. So again, it is the same thing. As we have already wasted time, I'll not go into these two tables, describing each lesion slightly in a bit detail as to what is their prognosis and recurrence risk. So looking at the dandy Walker malformation, because this is commonly encountered and asked for prognosis, it is a posterior fossa anomaly characterized by agenesis or hypoplasia of the vermis. As I said, there's a cystic enlargement of the fourth ventricle causing upward displacement of tensorium or torcula, and the hydrocephalus is a frequent finding. In a Dandy Walker variant, the fossa cyst is present, but there is a variable hypoplasia. The cerebellum is not very hypoplastic, and there will be a small communication channel between the cisterna magna as well as the proton. A megacisterna magna has no communication. It is that enlarged cisterna magna. And we discussed in the slide that the prognosis is very good, with only 3 to 8% of them having some minor neurological impairment. If you look at the outcome of Dandy-Walker syndrome, the prognosis largely depends upon the degree of hydrocephalus and the presence of associated abnormalities, and also the extent of hypoplasia the cerebellum has. In most of the studies, a pure developmental outcome is reported in almost 55 to 100% of the cases. So this is another anomaly which generally invites termination if it is detected early. And approximately one third of the patients of Dandy Walker will have severe developmental delay. So almost 80 to 90% will have some delay, and nearing 30 to 33% of the patients will have severe neurodevelopmental delay. And even the mortality in the early infancy is up to 30 to 40%. So that is the prognosis of Dandy Walker syndrome. Classical Dandy Walker syndrome is not good. Then we come to the last anomalies. Those are the vascular abnormalities. So the only vascular abnormality which is detected antenatally and of a concern is the vein of Galen AV malformation. And they are the shunts that form in utero between the choroidal arteries and the precursor of the vein of Galen and median prosencephalic vein of Markowski. So if you look at the literature of vein of Galen, mostly they are case series, with largest case series I think being of around 22 cases. And there are variable prognosis based on the feeder vessel, whether it is large or it is small, and the intervention, whether it was done early or late, and the high output cardiac failure, whether it presented at birth or it took certain time to present. For example, we had 5 cases in my knowledge till now, and almost 4 of the cases they expired before they could get discharged or before they could find a way out of nursery, and only one case embolization was done, and that girl is now 4 years old. So you can say that almost 10 to 15% of these cases they survive, and they will have some amount of neurodevelopmental outcome abnormalities, and nearing 75% of these cases they die within the first week or during their neonatal period. So these are the important categories of antenatal CNS malformations that generally the fetal medicine specialists and the neonatologists encounter, and where the prognostication has to be done. And somehow I have tried to give overview as to what prognostic determinants are there in these malformations and what are the outcome of these babies with the current management strategies. Thank you.
Thank you so much, sir, for simplifying that topic and taking us through some of the common antenatal CNS malformations. And the majority of us are stuck which way to go. If we have any questions, the participants can unmute and ask directly. Sir, one of the participants wants to know whether is there any medical management of myeloma or meningocele before surgery?
So essentially, as this is a disorder where the problem with the closure of the neural tube defect, so there would be no medical management as such. But definitely, as I said, that in the first week of life, the most concern is the infection, and these surgeries have to be done early. And before you do the surgery, one can start the prophylactic antibiotics. And the moment the surgery is done and the defect is closed, generally the antibiotics are stopped, within 3 to 4 days. So that is how one can prevent the early mortality. The other thing is the prophylaxis. So the secondary prophylaxis is there, especially and as well as the primary prophylaxis by supplementation of folate that has seen to reduce the incidence of neural tube defects. And there is also a drive to have fortification of different wheat flour, etc., in areas where the incidence of neural tube defects are high. But as such, just to close already when the NTD has occurred, to facilitate the closure, I don't think currently we have any medical line of treatment.
So the other important and practical questions regarding the timing, sir. Uh, is there any
Yeah.
minimum weight criteria, or it should be an immediate surgery?
So if you look at the surgery, if it's a open lesion, so I discussed about the spina bifida. There are two categories. One is the open lesion and one is a closed lesion. So if it's an open lesion, then you're sitting at a very high risk of early mortality if you don't close that particular lesion. So these lesions are the rule of thumb is to close them as soon as possible. There is a variable opinion among surgeons whether the associated hydrocephalus should be managed in the same sitting or it should be managed after some time. So there is a difference in opinion about the management of hydrocephalus and placement of the shunt. But as far as the closure is concerned, there is no two opinions about it. The open lesions should be closed as soon as possible. Now, when we come to the closed lesions, then you can follow up these patients if there is a good skin covering over the lesion and you are sure on transillumination and ultrasound that it doesn't have any neural elements. Then if it's a meningocele which is covered nicely by the skin, then you can wait for some time and then close it at ease. But as far as the open lesions are concerned, they are to be closed as soon as possible.
Any other question? You can ask directly or post in the chat box. You can unmute yourself and
So I was just looking at the chat box.
sir, for fetal MRI, what is the
Okay.
indication and when should we ask the mother to undergo it?
So if you would go to the presentation, there was a mention about fetal MRI at certain places where the diagnosis is very apparent. For example, in neurotube defect, then you don't need any fetal MRI as such. But many a times, as I said, that if you're looking at the ventriculomegaly, which is moderate to severe, or for that matter, in certain cases, you're looking at a mild ventriculomegaly with a soft marker, and you want the etiology is not very clear. So in those cases, the fetal MRI may be of some benefit. Otherwise, a blanket fetal MRI for all the CNS anomalies is generally not recommended.
Although you have covered this in your presentation, so but for the benefit of the listeners, they want to know that what are the lesions where we should consider termination of pregnancy?
See, it's very important that we are not judgmental about these things, and always the parent should be taken into loop and their decision should be respected. And with the new MTP Act, if a parent is not ready to handle a disabled child, or he has taken a calculated decision that he is not able to accept because of any social or family reasons a disability, then the termination can be discussed with him. And now under the MTP Act, the case can go to a board even at any gestation, and depending upon the patient's interest, the board will take a decision and these anomalies can be terminated. There are certain frank lethal anomalies where the termination can be considered. For example, as I said, encephalocele, Dandy Walker malformation, other posterior fossa abnormalities with associations like hydrocephalus and thoracolumbar meningomyeloceles with hydrocephalus. So we know that wherever the prognosis is bad, the neurodevelopmental outcomes are beyond 70%. So these are the facts we have to lay in front of the parents. So essentially, our role should be to lay down the prognosis that these are the chances that the baby will survive. These are the chances that if the baby survives, he will have disability. And these are the various disabilities the baby will have. And these are the long term complications the disease may manifest. So these sort of should be kept on the table and clearly explained to the parents. They may take one visit or two visits to assimilate the various knowledge you are given, and then the parents' decision should be respected. So that is how the termination decisions are taken. But it is absolutely not indicated, neither it is advisable to be judgmental and advise for termination for that matter in any of these anomalies.
Other regarding vein of Galen, what is the ideal management, and if one is to go for surgery, what should be the timing?
See, as I said that I have very little experience. We had only 5 cases, but the main challenge to a neonatologist is the high output cardiac failure. So I think that is one thing where you'll find very little literature. We searched a lot about how people manage high output cardiac failure, because in these cases, the inotropes will be going with the pathology, and actually, it's a very difficult situation to manage these babies with high output failure. And 3 of our babies, in spite of all our efforts, we could not manage them. So I find that the most important uh, aspect as far as vein of Galen malformation is concerned is to see how the high output cardiac failure can be managed. Because unless you manage this high output cardiac failure, the neurosurgeons will neither take the baby for any embolization nor any coiling. So once this particular challenge and hurdle is overcome, then the neurosurgeons are still comfortable to follow up the baby on medications and operate when the baby is slightly bigger enough. And I think they have certain wires and all that which are of a particular size, and that generally is a time around 4 months, 5 months to 1 year when they do the surgery. But yes, embolizations can be done earlier, and only few centers have the expertise. But the challenge to us is to keep the baby alive and manage his high output cardiac failure. And that is what we faced in all these babies. Only one baby we could manage, and we could manage because he didn't have a very severe high output cardiac failure. So it's by God's grace that his cardiac failure was, because the feeding vessel, if it is small, then the high output cardiac failure chances are less. And this baby, however, eventually got operated. So that is how we could save one child. But otherwise, it's a very pathetic situation where you see the baby dying in front of you and you cannot do anything.
If anybody else wants to ask question before we can call it a, I think we have no more questions, sir.
So thanks everyone. Hope I've done justice to this topic, and apologies for the technical glitch we had in the beginning. So thank you very much. Thanks for the.
Thank you so much, sir, for such a lucid and informative talk, and we'll take many points from this lecture and put it into practice into our day-to-day neonatal care. Thank you so much, sir.
Thank you. Thank you, everyone. Good night.
Good night, sir. Thank you everyone for joining. With that, we'll end today's lecture. See you next week. Thank you.